Good afternoon and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network. Thank you so much for being here today, November 28th, for our Medical and Surgical Oncology Telehealth Lecture. Just a few things before we get started. If you're having any technical difficulties at all, now would be a great time to call us. We have technical folks standing by at 919-445-1000. Again, 919-445-1000. You may also email us at unccn@unc.edu. We're on the web at unccn.org. We're on Facebook, Twitter, YouTube, Instagram, lots of places that you can find out more about us. In particular, I'd suggest our website. Okay, we will be using Poll Everywhere today, and Dr. Park has included several polling questions, so it really improves the whole lecture if everyone is participating in these polls. I encourage each and every one of you to do that. There are two ways that you may participate from wherever you are today. The easiest way is just to go to the website for Poll Everywhere in our specific area of that, and you can do that with any web browser, including a web browser on a smartphone. You just go to pollev, pollev.com/UNCCN. So pollev.com/UNCCN. Whoops, and I didn't mean to advance or make the slide go back there. But you'll go there and you'll see those questions as they occur during the lecture, and you can answer them. That's an easy way. Another easy way is you can, with any phone that texts, go ahead and in the to field for your phone, type in the number 22333, and in the message field, type in the letters UNCCN. So 22333 and then UNCCN. Send that to us. You'll get a message back saying you've joined. Once you've joined, you'll just be able to respond to the questions as they occur. All right, and without further ado, let me introduce our presenter, Lisa Park, MD. Thank you so much for being here with us today.
Thank you.
Let's see, what do I know? I know a few things from your bio here. You are at the UNC Lineberger Comprehensive Cancer Center and you're a member and an assistant professor in the departments of psychiatry and medicine. And your primary goals are to elucidate the unique mental health and palliative care needs of parents affected by advanced cancer and develop evidence-based interventions to improve their health outcomes. And then I have a few other notes that say you're a principal investigator and co-investigator on studies addressing bereavement patterns among the widowed parents due to cancer and use of antidepressant medications in cancer patients and predictors of maternal depression. So great. Well, we are so glad to have you here today. What's something I left off? Maybe something outside of the professional realm that we should know about you.
Let's see, I just survived a 9-hour drive from Chapel Hill to Baltimore.
Wow.
Just a few days ago. So
any snow up there?
No, just trying to get my way through Thanksgiving traffic.
Okay, yeah.
But it was a lot of fun.
That 9 hours for what should have been 5.
Probably.
Yeah.
But 9 hours to hang out with 8 kids who are 5 and under.
Oh boy.
Yeah, it was fun. It was actually a lot of fun.
Well, if you survive that, you'll definitely survive this lecture. Absolutely. Okay, well, we're so glad to have you here today. Here's our first question. Hopefully this is easy for you. This is our icebreaker. So which of the following is a potential symptom of clinical depression? If you think having interest or pleasure in almost all activities most of the time is the answer, you would put in an A. You could say B, moderate high energy levels throughout the day. You could say C, able to focus thoughts, remember, and make decisions. That's C. Or ongoing sad, hopeless, or empty mood for most of the day would be D. So hopefully one of those stands out. And this is just kind of a practice question so that you'll have the feel for using Poll Everywhere if this is the first time. While I'm waiting for you to answer that question, I do have some disclosures. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. Dr. Thomas Shea consults with Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. Dr. James Coghill, MD, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. The speaker, Eliza Park, MD, has no conflict of interest relevant to this presentation. All right, so we've got that out of the way, and hopefully you all have a moment now to go ahead and answer our poll. Again, you can go to pollev.com/UNCCN or use the texting method that we mentioned. We're looking like we're 100% on D. Dr. Park, how are they doing?
Okay, I don't need a lecture. Everyone's passed.
You passed. Well, this is a great topic, understanding and treating anxiety and depression in patients and with families with advanced cancer. Okay. So I'll go ahead and pass the controls on to you. Absolutely.
All right. So quickly as an overview with respect to learning objectives, by the end of this discussion, the goal is that you'll be able to describe the epidemiology of depression and anxiety disorders in patients with cancer and their family members, and recognize some of the initial pharmacologic and non-pharmacologic treatment strategies for these symptom clusters, and also identify some of the major risk factors for suicide among patients with cancer. This is a pretty clinically focused talk. I mostly do research these days, but I still maintain a pretty active clinical practice part-time within the cancer hospital, so it's always fun to be discussing kind of the bread and butter of kind of how we approach and hopefully help our patients who are experiencing these symptoms in the context of their diagnosis. So my first question here is a question with respect to anxiety and whether respondents feel like anxiety is a normal adaptive response to a cancer diagnosis and its treatment, or if you feel like it's a symptom or disorder leading to disruptions in cancer therapy or impairments in functioning. And I'll give you a minute to complete the poll.
All right, and thank you all for, I see some folks are quick with their fingers already.
I'm impressed.
Getting that answer in, and we'll wait just a few seconds more. Thank you. More answers are coming in. Shifting a little bit here. All right, how are they doing?
Okay, well, I will say that you guys are more technologically advanced than I, which is amazing. And also, it's a little bit of a trick question because everyone is right. I think this all exists on a spectrum. And by that, what I'm going to move to is the next slide here, which I think we're all going to be familiar with, which is looking at this language of distress. And as everyone at UNC is well aware of, as at many other cancer centers, distress screening is now mandated by the American College of Surgeons and the Commission on Cancer, which dictates that for patients who are being evaluated and treated at comprehensive cancer centers, that distress screening, psychosocial distress screening, needs to be a standard part of practice. And when you do this from research studies or from other cancer centers, approximately 40% of patients and caregivers are registering as having clinically significant distress. The most common way that institutions typically measure this is on the distress thermometer, which is located on the slide here, which essentially is a kind of almost a visual analog scale of how stressed are you. And the takeaway here is that it all exists on a spectrum. A life without distress is probably unrealistic, particularly within the spectrum of cancer. And yet when it becomes more clinically significant or symptomatic anxiety or depression is a fine line that I don't always necessarily have the answer to, but I will hopefully give you some ideas about kind of how we wade our way through some of these different decision points. If you look at the NCCN definition of psychosocial distress, in some ways it's not terribly helpful, but I put this up here just because I think this is the rubric for which we're all operating under, which is that it's a multifactorial unpleasant experience of psychological, social, spiritual, and or physical nature that may interfere with the ability to cope effectively with cancer, its physical symptoms, and its treatment. And certainly I think that anxiety and depressive disorders are an aspect of psychosocial distress, but only one part of it. And I say this because I think psychosocial distress is not a single construct. It may or may not reflect depression or anxiety, which is, I think, what we typically necessarily kind of jump to. But to be truthful, it may also just represent existential dread, worry about finances. Financial toxicity is, I think, a very real aspect of cancer care. It might be embarrassment. And it may not be the same in all patients, or even same in the same patient over time. But what I do think it is I also say this because it's not always a cause for intervention, but screening is only part of the answer, and it's not always the end of the conversation. but it's oftentimes our gateway. And going back to the original poll everywhere question, which is, you know, in the essentials thing, which is that I consider anxiety and depression symptoms to be a normal response to serious illness and end of life, which by very nature includes diversity of emotions, including anger, sadness, worry, loneliness, fear, as well as hopefulness. I always find it reassuring to tell patients and their family members that the evidence base does not suggest that a specific coping style is associated with mortality risk. We often hear patients saying, I've got to stay positive because that's going to help beat my cancer. There have been studies that have demonstrated that having a certain positive outlook versus not is not necessarily associated with what happens with your cancer down the road. That most patients are going to oscillate between competing styles and outlook and symptoms, and there are a significant minority of patients who are engaging in some form of denial, but this is a relatively smaller number of individuals. And so when I think about kind of understanding anxiety and depression within a cancer context, it usually is going to start from a screening. Occasionally patients will present to us and say, I'm really struggling with this, I need help. More commonly, as we're seeing changes with implementation of the stress screening, I think increasingly we're going to start to see it occur through more standardized measures. I say that because we start to roll this out. I have a little bit of my own distress about what will happen next when we do it more universally here. But I think of this as a clinical pathway to help us better manage depression and anxiety disorders within cancer care, because we know that we're probably not addressing the needs of patients adequately just through standard usual care. Brief screens like the distress screen are a kind of intro or a relatively rapid way to identify kind of how stressed someone is. And by that, I mean, is this something that's part of the normal spectrum of cancer care, or is this something that might need more clinical intervention? But screening is only part of the answer. It usually needs to be followed by some sort of assessment, where I think oftentimes the next step is to figure out if this is a mental health need, kind of does it need clinical intervention, or do we think that this is going to get better on its own with time or with the resolution of the acute stressor, and really help determine whether or not someone needs to be coming to someone like myself for a more comprehensive evaluation to establish diagnoses or a management plan. So I'm going to start with anxiety disorders in oncology, partly because they are by and large the most common, and I also think they're a little bit harder to manage because anxiety is so multifaceted and actually has many positive benefits with respect to how someone may respond to stressors. And I say that because, as we know, I think a little bit of anxiety is probably a good thing. It makes people probably adhere to appointments, to their treatments. We probably all know someone for whom we wish sometimes they had a little bit more anxiety about certain things. And it's also extraordinarily common even in non-oncology populations. So anxiety disorders are the most common kind of DSM, which is the kind of diagnostic manual we use in psychiatry, to put a label on symptom clusters. And it's the most common kind of psychiatric symptom that you're going to see across individuals or adults in the United States. So even before a cancer diagnosis, you have a significant proportion of individuals who have a propensity towards or have a well-established anxiety diagnosis. But nothing quite like having a serious illness that is potentially life-threatening that can really take that up several notches. For the issue that I often think about is whether this is persistent or chronic, and these are the folks for whom we oftentimes will want to intervene. And oftentimes I think about this with respect to kind of as a difficulty with adaptation, which is that life is full of uncertainty and unpredictability, and for some individuals it is much harder to cope with those changes or uncertainty than it is for others. And this is based on a whole host of temperamental and genetic and biologic and psychosocial factors that I think we're all aware of. When I think about this in context, a couple of things to keep in mind is that, as I mentioned earlier, anxiety disorders are common, and their lifetime prevalence of anxiety disorders across individuals in the U.S. more broadly is a 33%. So 1 out of 3 U.S. adults over the course of their lifetime will be diagnosed with some form of anxiety disorder. Now, this may range from like simple phobias, which I probably have for many things that my young boys like to show me, because they're really into things like snakes and spiders. Or it may mean more clinically significant syndromes such as generalized anxiety disorder or social phobia. If you look at the kind of 12-month point prevalence in the United States population among adults, about 10% have what we consider like a diagnosable anxiety disorder. Now, the important thing here is that if you look across all cancer patients in these big epidemiologic studies, the point prevalence of a formal anxiety disorder among cancer patients is actually relatively similar to U.S. population norms. So it's 33%. So many of the patients that we see who have anxiety in the context of a cancer diagnosis may be just experiencing kind of normative symptoms, but a good chunk of them may also be a reflection of what I mentioned earlier in terms of a pre-existing anxiety disorder that's now being reactivated in the context of a cancer diagnosis. If you look at kind of studies of looking at symptom severity, the HADS is an abbreviation for a very common measure, and nearly 50% are having clinically significant anxiety symptoms. And this is important because anxiety in many ways is such a part of the cancer experience. So when you think about the prevalence of anxiety for cancer patients, it really depends on when and how you ask. If anything, anxiety is probably most prevalent before they really engage in care. It's when you know that there's something bad, but you don't know how bad it is and what it is. And those are actually the cases when we see anxiety symptoms ranging probably, these are from studies, but from 21 to 54%. It's probably higher than this. This is a little bit dated. And then what we often typically see are substantial declines during treatment. They probably cut in half. And I think oftentimes that's because once you start care, your job as a patient and as a family member are often much clearer. Your job is to engage in treatment. And so particularly for patients who we see with spikes of anxiety pre-treatment, I like to think about the time course here and how much I might expect things to improve just with changes in their cancer care. Post-treatment anxiety is variable. Depression is actually far more prevalent than anxiety, but there are a proportion of individuals for whom anxiety becomes a persistent problem. And this is data from a group in Italy that looked at trajectories of anxiety from baseline to 2 years after breast cancer surgery. This includes folks who received adjuvant chemotherapy as well as those who did not. And as you can see here, there's a real range. And the thing, I forgot to put a little kind of red circle on there, is that you're going to see that there's a good proportion of individuals who perhaps have clinically significant anxiety when they're first diagnosed, and yet that's going to go down. Those are the mild decrease and the low decrease. Those are the folks for whom, by and large, tincture of time will often be what they need. And yet the group that we really need to try to think about and try to differentiate are these groups with a high stable and a high decrease. So these are people for whom they're coming in already with high levels of anxiety and things aren't getting better, or persistent anxiety as a result of their cancer treatment or diagnosis. So when I think with respect to management, I like to focus more on actual what do we do about this, because I think most people who are coming in today are kind of engaged in clinical care, and I think as someone who does clinical care myself and just came from a meeting, I always want to know, so what do I do? And when I think about this, the questions I want to think about is, one, whether I think this is a temporary distress versus a manifestation of a new or chronic anxiety disorder. And that is for the first question that should really try to guide, do I need to intervene in a pharmacologic or non-pharmacologic manner? I also like to think about symptom severity. Someone for whom is having daily panic attacks or panic attacks even once a week is going to need a different level of intervention than someone who's just feeling stressed or thinking about things as they're going to bed. Important in this population is always to think about the physiologic contributors. We certainly have patients who present with anxiety, and it is underlying dyspnea or pain or hyperthyroidism that is actually a significant contributor to their presentation. And then the next thing I put in here is a risk for substance use disorders. And this is particularly important because it has impact for both their experience of anxiety as well as how we might manage them. I think that cancer for many individuals is a moment for individuals where many would like to try to cut down or readdress their relationship with substances. It is oftentimes what we call like a teachable moment. At the same time, it is also very helpful for managing anxiety for folks who have this underlying substance use disorder. And so in the context of putting someone in this situation that's highly stressful, when we think about exposure to potentially habit-forming medications, I like to know what am I getting myself into with respect as a provider, and how can I best help the patient so that we don't engage in further harm. I also like to think about life expectancy, because some of our medications do take some time to work, and if there is concerns that there is only weeks to maybe a couple months, then we would think about that with respect to management. And then finally, it's willingness to engage in treatment. So the initial step I'm going to focus on are assuming that we have folks who have ongoing, chronic, or severe symptoms. These are folks for whom the first line treatment should include SSRIs, SNRIs, or mirtazapine. These are standard antidepressants. I think it is important to educate patients that these are FDA approved not just for depression, but also for anxiety. As I mentioned earlier, they have limited value if someone has a limited life expectancy, in which case I wouldn't necessarily go down this route. And I think the questions that we often see most clinically are kind of, what do we do about folks for the immediate symptom relief or medications that they could use as needed? And the three main classes that we'll see are benzodiazepines, the non-benzodiazepines anxiolytics, for which most of this is off-label use, or neuroleptics, which is another word for antipsychotics. And I listed here probably the kind of 5 most common classes that we'll see used within the non-benzodiazepine anxiolytic category, as well as most commonly used ones we see for neuroleptics. The big decision point that I often think about in my head is, I'm going to skip through it and come back if I need to, is whether or not I think someone will be a good candidate for benzodiazepines. This is what they are used for. They are excellent medications for anxiety. They also come with real drawbacks, as we know. The benefits are that immediate symptom relief, as you all know. I think there are multiple routes of administration. They are helpful for a variety of symptoms, including anything from muscle spasms to insomnia, nausea. And the big things here that we always worry about are, one, the addiction risk, tolerance and withdrawal, and then the kind of broader effects systemically with respect to respiratory effects, daytime sedation, cognitive slowing, falls. And the question I am often asking myself is, do I think that this is someone for whom this medication would be helpful, or do I need to think about other less habit-forming medications? And with respect to this, I think patient selection and education are key. The main things I will tell patients, and I think it's worthwhile to keep in mind, is I tell them these are more helpful to you the less you use them. And if you're having to use them every day for any period of time that's longer than a couple of weeks, then I think we need to be looking at other options. And I think if you think that this is a patient for whom that is the case, then this is probably not, this may not be someone that you want to lead for in terms of their treatment, or you should be probably initiating an SSRI or SNRI or mirtazapine along with it. The prescription database monitoring program within North Carolina is greatly expanded. It allows us to evaluate whether or not there's concern about co-occurring prescriptions or previous use of benzodiazepines. I encourage anyone, whenever you're considering prescribing these medications, to consult this program, similar to opioids. Clinically, we end up using lorazepam or clonazepam the most frequently. Both are metabolized through the liver. Clonazepam is much longer acting in duration, though also a little bit less potent with respect to kind of how it feels to the individual. The main caveat I would say is, if you were to use a benzodiazepine to help manage anxiety, I would recommend one of these two. I do recommend trying to avoid alprazolam if at all possible, because of the short half-life and the fact that it usually requires multiple dosing and is therefore easier to develop kind of dependence with that formulation. And the truth is that psychotherapies and non-pharmacologic therapies really should be the basic standard of care that should be offered and provided to patients whenever possible. I think this is actually extraordinarily effective for motivated patients. Cognitive behavioral therapy is extremely well studied and very well and is extremely effective in treating anxiety for patients with or without cancer and their family members. It does require specialized training. I would say for folks who are not mental health trained, even briefer things such as guided imagery, relaxation training, mindfulness exercises. There are apps that we can provide to patients, and I'm happy to, if people want to email me, I'm happy to provide my big dot phrase that lists out all the kind of iPhone, Android apps I give to folks with examples of these. There are patients I've had who have panic attacks in session, and I'm not asking to take a pill. We're sitting together and doing some guided imagery for 5 minutes to help recenter them. And these are things that can be done by clinicians and family members outside of mental health. So with that, I'm going to now move to depression disorders in oncology, which are a little bit less common, but also I think sometimes a little bit easier to kind of know how to approach. And when we think about depression in cancer patients, we know that cancer itself is a risk factor for depression. When you look at more bigger epidemiologic studies, nearly 1 in 5 patients who are seriously ill meet criteria for a major depressive disorder, and the prevalence increases as your physical symptom burden grows. And the risk of a major depressive disorder within a cancer diagnosis is not universal. And in fact, patients who have head and neck cancers, pancreatic cancers, breast cancers, and lung cancers are at much higher risk than individuals with other disease types. It's not to say those other individuals are not at risk, but by and large, there's a differential risk depending on your cancer type. And the reason why we care about depression is it makes everything worse. We know that it worsens the severity or perception of pain and other symptoms. It decreases functioning. It worsens quality of life, and I think that is in and of itself important and worthwhile of intervening upon. But with respect to cancer outcomes, it's associated with worsened health behavior and decreased adherence to cancer treatment. And there's actually a lot of very compelling data that demonstrates that a depression diagnosis increases your risk of mortality related to cancer, both as a suicide or as directly from your cancer itself. There is very fascinating data from colleagues of mine in other institutions that have been looking at some of the kind of immuno and behavioral mechanisms that might kind of mediate this relationship. In fact, depression may have an effect on cancer-related mortality and your immune functioning separate from health behaviors. And it also increases cost. And I think that is something that the language I think pretty much everyone can understand is associated with increased healthcare utilization, it's associated with increased duration of hospitalization, and these are all things that, by and large, we would like to try to decrease if at all possible. So when you think about risk factors for depression and serious illness, by and large, everybody is individual and everyone's going to have their own personal risk factors, but in terms of the kind of bigger picture, we know that younger individuals are at greater risk for depression. I will say that when a cancer diagnosis occurs at a time when you are younger, it's more disruptive. The diagnosis itself can feel more disruptive because it's coming at a time when it's kind of less expected. By and large, a prior history of depression is a very significant risk factor for the onset of depression during cancer treatment. Uncontrolled physical symptoms or symptom burden, the cancer type, like I mentioned earlier, as well as treatment. For example, many of our anti-neoplastic therapies, while extremely beneficial for the disease, also have neuropsychiatric side effects. You give enough steroids to someone long enough, a vast majority of them will develop depressive symptoms. The rates of co-occurring depression symptoms with endocrine therapies for prostate cancer or for the breast or gynecologic malignancies are quite high. Although less frequently used now, interferon is very much associated with depression symptomatology, as is CNS involvement from primary tumors. So all this to say is that there are lots of risk factors for depression specific to the individual. And what becomes a little bit hard about trying to understand what is depression versus what is kind of response to illness, this is unfortunately some of the places where the standard kind of DSM or kind of the psychiatric manual that helps kind of categorize psychiatric disorders is a little bit less helpful. This is actually kind of the definition, which is at least 5 symptoms over a 2-week period and represent a change in functioning. The core symptoms are depressed mood or loss of interest, which is known as anhedonia. And then I put on here kind of the acronym that most of us are taught in medical school to help us remember what are the core symptoms. And the key here is that things such as sleep disturbances, loss of energy, changes in concentration or appetite or psychomotor retardation, which means slowing, these are all things that are fairly ubiquitous during certain phases of the cancer diagnosis and treatment. And so you don't want to necessarily ascribe these to a depression disorder when they could be due to other reasons. So when I think about key features of depression in the medically ill, I will tell folks I think having sad mood, some grief, or anticipatory feelings of loss with respect to how your life has changed are appropriate and part of the experience of living with this illness. However, symptoms that I personally look for when I'm evaluating someone for a depression disorder are kind of persistent feelings of guilt or worthlessness or hopelessness, kind of notable social withdrawal or deep changes in your functioning that can't be explained by physical symptoms. For example, someone staying in bed even though physically there is not a reason for there's not a physical kind of etiology for that, as well as suicidal ideation. These are some of the more core symptoms that I try to assess when we're seeing people. And some of the questions that we use to differentiate are, these are some of the words I sometimes will use, which is either moments you can still feel joy despite the sorrow or difficulty you've been going through. I'll ask people what keeps you going on difficult days, where they draw hope. If you could do more physically, would you be doing more physically if you could? Whether or not they feel like they're to blame or deserve their illness. These are just some ways to kind of help differentiate what could be due to just, feeling frustrated or perhaps sad about your diagnosis in the context of, substantial symptom burden versus an underlying depressive disorder. And the truth is that you can also go about this a little bit more simply. There's been good studies that demonstrate if you just ask someone, are you depressed? The data shows that a single question screening is both sensitive and specific. So those are some of the more nuanced questions I gave you earlier. But for many of the clinicians who are listening and are not necessarily doing a more comprehensive evaluation, just asking this question alone can get you, I think, a good chunk of the way there and help guide next steps. That being said, treatment of depression and anxiety disorders is difficult in cancer for a lot of reasons. One is that there's a fluctuating course of illness. Things are always changing with respect to symptoms, the treatment phase, towards life expectancy, and so therefore it's sometimes hard to know when to intervene, if you should wait, or whether we should just treat now. There's also shared symptoms with other disorders like the cancer. There are a lot of patients who are going to, and family members who are going to perceive symptoms as appropriate, even perhaps when they are not. And so I think overcoming that perception can be difficult for patients to seek help or to recognize symptoms as perhaps causing more problems than they recognize initially. There can be sometimes reluctant to treat patients with limited life expectancy. Oftentimes we have to initiate treatment before we see necessarily the full impact of intervention, though we oftentimes will try to tailor it based on prognosis. And I will say that there's a really poor evidence base for how to best treat depression in the medically ill. I have contributed to that poor evidence base. It's really hard to conduct the kind of rigorous studies to address pharmacologic interventions for depression in oncology patients because these kind of individuals will be screened out from standard clinical trials within mental health fields. And when we get to the point where you're seeing a patient with a serious diagnosis like cancer who's experiencing depression, most of them just would like to just start treatment that's going to work. And given that there is compelling evidence just clinically that these medicines can be helpful, most of them don't necessarily want to sign up for a study. And again, there's drug-drug interactions as well. I put this slide in here because I think it's important to recognize that depression actually exists along a continuum. We know that cognitive changes from cancer and its treatment are extraordinarily common. Within a subset of patients, delirium, which are kind of these acute confusional states, are also an aspect of the symptom experience. And that these are all probably related. They have shared risk factors, and a depression diagnosis puts you at greater risk of cognitive impairment and delirium, and these also subsequently put you at greater risk of a depressive disorder. So although we know that depression is common and that it's hard to necessarily know how to address it, the key here is that we're probably not doing a good enough job. This is data from a colleague of mine who's based in the UK, where presumably there's a universal health system that can kind of better kind of identify and therefore manage these individuals. And in a study of over 20,000 patients, what you can see here, this is among individuals with cancer, of the over 1,000 individuals who met a criteria for a major depressive disorder, so not just depressive symptoms, but kind of full-blown major depressive disorder, there were nearly 3/4 that were not receiving any form of treatment. And that could mean psychotherapy or could mean pharmacologic intervention. And this is probably happening in a system that's better equipped than ours. And so they've actually done a next step here, which is like, okay, well, what if you actually try to intervene upon this? And this is an integrated care model where you pair an oncology RN with a psychiatrist. And they've run two separate big trials now called Smart Oncology 2, which is for the better prognostic cancers, and then a separate one for the poor prognostic cancers, which is Smart Oncology 3. And the takeaway point here is that if you can systematically screen and implement some brief behavioral therapies and have a psychiatrist help manage the medications, not directly, but oftentimes through a primary care doctor or oncologist, you can very effectively treat depression and improve patients' quality of life, and it's actually quite cost effective. It met the criteria for which Britain uses to determine whether or not an intervention should be implemented based on cost analyses, and it works. Now, one of the questions that we always get asked is, since we know depression and cancer is associated with mortality, does treating depression and cancer actually decrease the risk of dying from their disease? And the answer is probably not. A secondary analysis from this 2 studies I mentioned earlier did a follow-up analysis, and what they actually found was that there's, as you can see here from the Kaplan-Meier curves, no differences, at least no statistically significant differences. That being said, I think that alleviating distress and suffering and improving quality of life is a worthy outcome on its own. So when I think about prescribing, I think it's always important to look at the co-occurring medications. I'll talk about drug-drug interactions in a little bit, asking about substances, since we know that those can be related to symptom experience and how people cope. I also like to ask everyone to consider bereavement and demoralization. I think anticipatory grief among patients and their family members within the context of a life-limiting illness is common and appropriate, and that may be contributing to their experience. Evaluating for cognitive disorders, like I mentioned earlier, given the shared risk factors, and ruling out medical conditions. So making sure that we're not trying to trace a primary psychiatric presentation that is actually undiagnosed anemia or hypothyroidism. Hypothyroidism is important. So when I think about pharmacologic considerations, I often recommend for non-mental health providers that they know a couple of medications from 2 different classes relatively well so that they feel comfortable initiating treatments. The treatment of depression in oncology for cancer patients is the same as it is in non-oncology patients. So same medications, but I often say slower and with a lower initial dosing. That being said, with the caveat that you still need to make sure that you titrate to therapeutic efficacy. So if you're starting lower, actually continuing the dosage monitoring to get them to the dosage that we expect them to actually have symptom benefits, really critical here. I often will try to evaluate for symptom clusters to guide initial treatment selection. And important, I think it's also really critical to ask about prior treatment response, particularly for folks who have a history of depression or anxiety. If someone has done extraordinarily well or even moderately well with a medication previously, then that should probably be the one that you start first. With respect to pharmacologic considerations, SSRIs are the typical first-line choice. And I say except because within the oncology population, we oftentimes will first jump to a medication that's fairly rarely used as first-line therapy in the non-medically ill, and that is mirtazapine, also known as Remeron. And the reason for that is because it is associated with both appetite stimulating effects as well as some sedating effects. So using that to help with kind of appetite and sleep in our oncology patients is usually highly desirable. If I expect someone to have neuropathy in the future, or they already have neuropathy, and they meet criteria for depression or anxiety for which I would want to start treatment, then I would often recommend not starting with SSRI, but rather the SNRIs, oftentimes because these can have dual effects to help with peripheral neuropathy. And for individuals for whom appetite reduction and or wakefulness is desired, then bupropion is actually a very appropriate first-line agent. So I put on here mostly for your, not to go over, but for you to have as reference are some of the major kind of adverse effects with the kind of 4 major classes that we use for treatment of depression and anxiety for the SSRIs, SNRIs, mirtazapine, and bupropion. The lists here are meant to not be scary. I will say that some of these adverse effects are pale in comparison to some of the similar adverse effects we might see for their primary antineoplastic therapies, so I always kind of keep that in mind. When I think about kind of pharmacologic treatment for folks with more advanced illness, I will go ahead and say that the evidence base is really thin. There are no recent randomized controlled trials of primary antidepressant therapy for patients with kind of more advanced or incurable cancers. And this is including for individuals with ketamine, for which is becoming an emerging strategy for treatment of depression, particularly those who have not responded to other treatment modalities. Oftentimes, I will use methylphenidate or the stimulants as add-on therapy for folks with advanced disease for whom I expect the progression or natural course of their illness is to have increasing fatigue, sleepiness and symptom burden. But again, this is the data here is actually a little bit mixed. There's been a couple of big studies that have looked at the role of using methylphenidate plus an SSRI in advanced cancer population, and they showed no difference. There was another study that's looked at methylphenidate with mirtazapine and demonstrated benefits for the combination, but this was a smaller study. And so I think that the data here is mixed. Oftentimes, if I think there could be a benefit for the advanced population, then I will try to use both of these in a way that I wouldn't necessarily for folks with a disease that's expected to be easily treatable and curable. So in terms of thinking about management, I think about titrating, switching, and combining antidepressants. By and large, it's pretty rare to get someone to a full titration or kind of fully therapeutic efficacy dose within 4 weeks. That being said, there are a proportion of individuals for whom they will respond to initial therapies within the first 4 weeks, but that is certainly not everyone. And so if you're seeing no response after 4 weeks or a partial response after 6 to 8 weeks, then the first step is usually to increase the dose. What I see oftentimes is someone who is kind of a consultant is I often see folks come in and they're just, part of what I just need to do is get them to the appropriate dosing range. For folks for whom after you have gotten to, if someone has truly had zero response and they're on a kind of moderately effective dose, then I think this is the time to consider either switching antidepressants or combining with antidepressant or another treatment modality. I often get questions about whether we should do a cross taper versus just switching. I think if you have someone who's on an SSRI and you want to switch them to a different SSRI, you can just make a direct switch. If you're going to switch from an SSRI to a medication in a slightly different class, so for example from an SSRI to mirtazapine, then you're going to want to cross taper. Or you could try to combine with an antidepressant of another class. And I will typically go down this route for number 3 if I think that someone has a history of more persistent depression symptoms. Most folks for whom this may be their first presentation of depression, if they don't respond and you've increased the dose, I don't recommend adding on, I recommend switching. And then finally, you can try augmenting with another psychotropic agent. In particular, we often see that depression and anxiety kind of run together, and so patients can have symptoms of both depression as well as anxiety, in which case then you may see patient use a variety of other treatment options. These include things like psychostimulants. The most common ones that you'll see used are methylphenidate, which is the Ritalin preparations, dextroamphetamine, which are the Adderall preparations, the wakefulness promoting agents, modafinil and armodafinil, T3, which is kind of exogenous thyroid hormone. And a lot of data in the non-oncology patients about using ketamine as well as ECT and TMS. I think the latter category here of ECT and TMS is probably underutilized. Many oncology patients do not have contraindications to these treatment modalities. By and large, they're extraordinarily effective at treating kind of more treatment-resistant depressions, and so something to consider as well. So I mentioned earlier that I look at symptom clusters, and I often think about whether or not comorbid pain is a factor. Pain is a fairly ubiquitous symptom for many cancer patients, particularly for those with exposure to certain adjuvant chemotherapy regimens or depending on the tumor site. For many, for non-opioid analgesics, antidepressants are actually the first line agents for treating kind of anything for adjuvant therapies for pain, particularly neuropathic pain. The two main classes you're going to see are the tricyclic antidepressants as well as the SNRIs. I will say that tricyclic antidepressants, if you're going to be trying to treat both depression as well as pain, this is probably a class where you're going to want to refer to a mental health specialist because they are a little bit trickier to dose and have guidelines with respect to laboratory monitoring. If you are going to start one, my own request is that you try to focus on nortriptyline or desipramine because these are medications that are better tolerated. They have lower anticholinergic effects, so they're by and large are hopefully safer. I typically see amitriptyline or Elavil used. Sometimes I think it's because it's kind of got a catchy name, and I think you learn from our apprenticeship of residency or training, etc. But this actually has a fairly higher anticholinergic burden, and it's rare that I can get a patient to tolerate therapeutic doses of amitriptyline for depression. So if you're going to be if you're starting an antidepressant, a tricyclic for kind of neuropathic pain and depression, I recommend trying to start with the other two as opposed to amitriptyline. More commonly, you're going to see the SNRIs used if this is a concern. So particularly patients who are receiving, for example, FOLFIRINOX or Taxol, and you have concerns about this, then SNRIs may be a good first-line agent. I've listed the three that are now all available generically. The key things I put on here that if you are trying to treat both pain as well as depression when you're using venlafaxine, then you really need to get the higher levels of the dosing range. And so patients who are not receiving benefit at the 75 or 150 or 137.5 dosings, it may just simply be because we're not at the therapeutic dose. And then with respect to drug interactions, I will say that polypharmacy is the rule. It's often easy to make things worse, but truly dangerous drug-drug interactions are pretty rare. There's lovely charts, or our medical record system can help you here. The only clinically significant one I do want to highlight is the role of tamoxifen with respect to many of the antidepressants. As we know that tamoxifen is a prodrug, the more kind of potent, biologically potent form is endoxifen, and that is metabolized through the cytochrome P450 2D6 system. And the big takeaway I want you to take away from this slide here is that the data is very conflicting. The old rule of thumb has been that treating a patient taking tamoxifen with any antidepressant, particularly those that are strong inhibitors of it, may increase their risk of subsequent mortality or recurrence from breast cancer. More recent data suggests otherwise. And in fact, there has been the most recent study that came out, a very well done study in 2016, demonstrated no increased risk of subsequent breast cancer or increased risk of mortality in women who were concurrently treated with tamoxifen and paroxetine or Paxil or other antidepressants. The reason why they use Paxil as a reference is because of all the antidepressants, Paxil is the agent that is most strongly inhibiting of the P450 2D6 system. And so even though I think oftentimes in our breast cancer patients who are taking endocrine therapy, there's a concern about limited dosing, limited availability of medications, I think the more recent data suggests that we can probably treat them as we would any other of our patients. And that being said, I think, as I mentioned earlier with anxiety disorders, combined treatment is best. And that if anything, I think pharmacologic therapies have benefits, but they are limited. And that individual group therapies, online therapies, more briefer therapies, or even just enhancing social support really are the cornerstone and mainstay of trying to assist patients. And so with that, I'm going to ask a quick question, which is, what is a possible initial pharmacologic or non-pharmacologic treatment strategy for anxiety and depression and cancer?
All right. And I see some answers are already up there from our previous poll, so we can ignore those. Oh, great. Here we go. So we will get to that question at the end if there's time. Right.
There has actually been, I was recently at a palliative care conference that had a packed room that was asking the exact same question about what role, if any, is there with respect to treating depression and anxiety with psilocybin or other hallucinogens.
So again, and we'll give you just another moment, another 20, 30 seconds or so for our audience. What is a possible initial pharmacologic or non-pharmacologic treatment strategy for anxiety and depression and cancer?
Yeah.
All right, so we have counseling and therapy.
Yep. It's a little bit of a trick question again, because basically I think all of the above. I really stress to individuals that I recommend, if at all possible, non-pharmacologic strategies, though oftentimes people are less interested in that.
What's your thought on exercise? We recently had Dr. Bonaglini and Dr. Wood talking about this on a recent presentation.
The data for exercise as a treatment for depression and anxiety symptomatology is so compelling. And I have a little smart phrase I give to patients for it. I think it depends a little bit on the patient's physical status and their actual ability to do so, that you can always find ways to do it somehow. And I agree that integrative oncology, one resource I always tell individuals about, since I think we always think we don't do a good enough job informing everyone of its availability is we actually have integrative oncology consultation available at UNC. It's insurance reimbursable. It is probably underutilized, and yet is a very holistic approach to trying to help individuals that we should probably be doing.
Great.
Okay.
Emotional support animals. Are you? I seem to be seeing more of those both at the cancer hospital and all over the place. Are you seeing an increase in that? And do you see a
when I'm on
that?
call in the emergency department, we certainly see that more often. I think, to be honest, they probably are extraordinarily therapeutic. I think there are some more complicated issues that become at play in the clinical setting. It is a little bit, if you want to actually prescribe, like to have a kind of verified emotional support animal, it is a quite extensive process. It's not just stress or depression alone is usually not enough to qualify someone to have like a prescribed emotional support animal. But do I think it's helpful and makes a difference for individuals? 100%.
Great. All right. Thanks so much to our audience for all those responses.
And then one last thing, as I think is also to help individuals think about, is how we can promote resilience in our patients. So I often will ask for prior strengths and life challenges and how they've overcome it, and really trying to engage the family to the extent possible when we can. And this applies for both caregivers as well as patients. I want to spend a couple minutes here because I think this is pretty relevant with respect to when should I try to pass this on to someone else to help manage from a psychiatric perspective. Indications for referral, I will say, is one, failure to respond to first or second line therapy. I often encourage my oncology colleagues to go ahead and start treatment for first line therapy, because many patients will respond to first line treatment or to perhaps referrals to support groups and may not necessarily need to see a specialist. If there's substantial significant comorbid medical illness for whom the kind of decisions about the initial treatment selection are complicated, absolutely indication for referral, as is suicidality. Anyone who's got a co-occurring psychotic or manic symptoms should be referred. It can get complicated quickly, and the treatment algorithms I discussed do not apply for individuals with significant psychotic or manic symptoms. And then individuals who have co-occurring psychiatric disorders. So in particular, I worry about folks who have personality disorders or substance use disorders. Those are individuals for whom usually specialist referrals indicated, as are patients with severe symptoms. And then finally, what I think are when we would like to try to engage in more comprehensive care, whether it's integrative oncology, consultations, or management, psychotherapy groups, and then particularly for these kind of high-risk populations, which are the younger adults, those with very lower social supports and distressed caregivers. By and large, I'm just going to, because of time, I'm just going to quickly say that rates of depression and anxiety, if anything, are higher in caregivers than they are in the patients themselves, and that the caregiving burden that we place on these individuals grows daily, and that the mechanisms how to best treat them are not robust because they're not considered patients of the hospital. But this is where trying to engage them with their primary care doctors is probably screening, and then referring to primary care is what I usually typically recommend. I'm going to finish off by briefly talking about suicide, because this is the stuff that can get scary. Cancer patients are at elevated risk, and most patients who do complete suicide with or without a cancer diagnosis have had contact with medical providers, not usually not mental health providers, prior to death. And in the AYA population, actually, the Medical Oncology Alliance is probably more important than any other mental health intervention. So I'm going to quickly kind of go to this question here, which is another work from my colleague, which is that if you just try to ask how many people, if you were to go to any cancer clinic and ask individuals, what proportion of individuals are having thoughts of suicide or being better off dead, the answer is about almost 8%. So it's a not insignificant number. So when you're looking at the volume of a lot of the cancer centers that we practice in, then we're talking about a large number of patients, dozens to hundreds. Now, in the same study, when they actually did a follow-up telephone interview, they subsequently found out that a third just filled out the questionnaire wrong, but a good another third believed that they were better off dead, but were not necessarily suicidal. But a full 33% of that 8% had clear thoughts of attempting suicide, and this is the group that we're really trying to alleviate and try to identify. And the important thing to take away here is that the relative risk of suicide It's not uniform. It's highest, the most proximate to a cancer diagnosis, and it's highest for individuals who have certain cancer types. In particular, pancreatic cancer and lung cancer and head and neck cancers are the patient populations for whom we should be the most worried about and for whom we probably need to take it more seriously. When I think about risk assessment, the things that I use to think about how worried should I be include aspects such as whether or not there's actually they have access to lethal means. Do they have access to a gun? Do they have social supports? Do they have a reason for living? Are they actually already involved with mental health care? Can I get them plugged into a therapist? These are all things I think, is this due to an immediate stressor that once the stressor passes, things will get better? And when it's too close to call, then the recommendation almost universally is to err on the side of caution. And I think it's important to think about this because it's a little bit different than desire for hastened death, which is actually quite common among patients with serious, particularly those with kind of incurable illness. You can think about it with respect to wanting to hasten your death versus kind of your strength or will to live. And they're not uncommon here. Studies have demonstrated pretty consistently 10 to 20%. And there's no real variables that really seem to distinguish between those whose thoughts go away versus those for whom it stays. We have general risk factors, which is by and large things that you might expect, which is depression, anxiety, and spirituality. But again, these are fairly loose. And so for folks who are depressed and have a desire for hastened death, I think of this as a opening for a next conversation.
Did you want to go ahead and take this question, or
should I just go ahead and do next?
We could go ahead and since we are running low on time, and then we'll have a Q&A coming up in just a moment.
Cool. Thanks. So the first thing I would say, if someone mentions this, the first step one should do is to acknowledge their request and just repeat them to make sure you're verifying your understanding, and use this as an opening statement, which is to try to clarify the underlying cause, which is, for example, I put some statements I think it's worthwhile to try to use, like, we haven't talked about this before. Can you tell me more? Or, what would help make life worth living? What can we do to help? These are very concrete things that we can do in response to these statements instead of ignoring them or telling them things are going to get better. This oftentimes is going to prompt and should prompt suicide screening because a desire for hastened death is distinct from a desire for suicide. And I put some examples, some phrasing that you can use to help if you find yourself in a situation, and then pulling for follow-up. And I do think it's important here, as it may mean getting someone like this into my clinic within this week. But in addition, even if you're referring to someone else, given that this person has felt that they can open up to you about some of their deepest, darkest kind of fears or thoughts, to actually follow up with them in some form or another yourself. So I think about the suicide assessment. I'm going to kind of end with kind of this last slide here, which is that most oncology providers are actually the folks who are on the front line, not the mental health providers. And I think an authentic therapeutic alliance is both protective and also key. I think we have to stay very humble since our prediction powers are extraordinarily poor. And so to the extent that we can at least screen for this, recognize it, and try to take next steps, which often include referral to mental health specialists and being vigilant about this risk is our role. And I think that most of my colleagues do an extraordinary job at this, and I have great respect for that. And so with that, I have time for questions. This is the CCSP. We're all wearing, we don't always wear matching jackets, but we did for this picture. And there's references at the end if people need it.
Great. And those slides are available online.
Cool.
So we'll go ahead and move to our Poll Everywhere slide. So now is your opportunity to go ahead and share questions with Dr. Park. So please, okay, and here we go. Though controversial, has there been any actionable progress in the use of psychedelics like psilocybin to treat depression? So that earlier question.
So the answer is yes. There is actually a clinical trial that's occurring right now looking at using, for example, like ketamine for treatment of co-occurring depression in patients with head and neck cancer. And that is happening, I believe, at UCLA. I don't think the results are known yet, but this is, I believe, a randomized controlled trial, which is the kind of data that we need to be able to kind of make more definitive statements. My go-to suicide assessment in P4, that's a good question. I didn't put in here because of time. If you actually go to the NIMH, there is a whole project called ASKEM, that's been initially developed for pediatric patients, but is, in my opinion, completely applicable to adult patient populations. That gives a template for brief screening, and then brief assessments, and then a full assessment. It's all freely available since you're taxpayer money, and it's designed for non-mental health providers. And so I encourage individuals to use that, actually. It's designed for folks in the medical settings.
Great. Let's see. Any other questions? Have you observed a higher risk in lower socioeconomic patients?
By and large, yes. So depression and kind of lower access to resources is a risk factor for, lower access to resources and financial distress is a risk factor for depression in the oncology population. So it is absolutely a higher risk. I think we see it both epidemiologically as well as clinically. And then I don't know how much time we have for questions, but the one question that has come up is with respect to prescribing olanzapine or Zyprexa for depression. As you all know, so Zyprexa is actually an antipsychotic. It has been recently demonstrated to be really effective for the treatment of kind of chemotherapy-associated nausea and vomiting. It is sometimes used off-label for depression. I will say that I do not use it as first-line treatment, in part because some of the toxicities regarding olanzapine, it's extremely sedating. When you use it more long-term for patients who are not kind of actively nauseous or with kind of reduced appetite, it will by and large induce metabolic syndrome and substantial weight gain. And for that reasons, I think that it is rare that I will use it for treatment of depression.
All right. Well, let's go ahead and wrap up there. Thank you all for participating with the questions and the polls and for being there with us today. A few things I would like to mention. We want to thank the generous support of the North Carolina General Assembly for the University Cancer Research Fund and UNC Lineberger Comprehensive Cancer Center. We want to thank my colleagues, Mary King, Veneranda Obore, and John Powell for all the hard work that they do for this and all of our lectures. Upcoming, we have an RN and Allied Health lecture on December 12th, Prevention of Chronic Postoperative Pain in Cancer Patients. This is a new topic from our originally scheduled one, and that's with Dr. James. And then we have another medical and surgical oncology lecture. These will be the last two of the year in our telehealth series, and that is on December 12th, an update on CAR T therapy with Dr. Grover. So we hope that you all will be able to make it. For those self-paced online courses, these are courses which were previously live courses and are now in our learning portal. And so we have Understanding Oncology Drug Interactions with Dr. Morgan and Aerobic and Resistance Exercise in Cancer Patients, Methods and Benefits with Dr. Bottiglini and Dr. Wood. That's the one I was mentioning earlier. We hope that you'll be, if you were not able to attend those lectures live, you can go back and freely access those, either just watch them or actually receive credit by watching and taking short tests at the end there. Thank you so much to all of you for being here. Thank you, Dr. Park. We really appreciate having you here. Until next time. All right. Thanks so much.